data to understand the relationship between lipid and cardiovascular disease, and then followed by the drug discovery. And then later on, a lot of clinical trials. And then how do we actually translate that evidence to practice? So we'll be, also on the other hand, there are also, as with all drugs, there are potential safety issues, not very common, but we have to be aware of it. But the point is, some of these events actually highlight some important principles of pharmacokinetics, pharmacodynamic, and also pharmacogenetics. So before that, I would like Dr. Chow would like to talk to you about the E module, right, of the Pharm learning, which is very important.
Yes. Yeah. So hello. So I'm Dr. Elaine Chow. I just want to take this opportunity just to mention that our pharmacology division has developed a series of E modules, which is really catered for the Med 6 senior clerkship. We are doing these electronic modules, which will be posted on the blackboard, and will cover some the very high risk drugs. For example, insulin, your anticoagulants, analgesics, drugs that are used very commonly, but if used incorrectly can lead to potentially harmful effects. These e-modules will be posted on the blackboard and will be released on the first of the month. So probably starting from next month, and you can complete them in your own time. So there will be a short PowerPoint introduction covering some of the theory, followed by maybe around 10 short questions, which are sort of mostly clinical scenarios and, helping you to apply your knowledge. So we are also in the process of developing another series of e-modules, which will be talking about, prescribing special populations. So in populations with, for example, renal failure, pregnancy, people immunosuppressants. And I'm very grateful to some of the medical the students who have helped me pilot this. So I think this will be maybe coming on, maybe towards later of the year. Okay, so thank you. So I will, ask Maureen to circulate the websites later. So I'll pass the time back to Professor Chan, who will talk about statins.
Okay, so thank you, Elaine. I think these e-modules are really very important for learning. So to participate, okay. So over the next hour, so let's talk about a few topics. Firstly, really reinforcing the global burden of cardiovascular disease and chronic kidney disease and the benefits of statin, which is HMG-CoA reductase inhibitors in reducing CVD. And how do we actually assess CVD risk and when do we start statins? We'll also talk about the pharmacokinetics and also pharmacogenetics of statin and some of the drug-drug interactions with statins and the use of statins, particularly in the context of CKD. And this is really quite important because particularly with most of these diseases, they are not acute, they are chronic. So as time goes on, right, as people get older, and then there might be more comorbidities, then what started out as a safe dose might later on become not so safe. And also we might have to actually look out for potential drug-drug interactions and then translating the evidence to practice. So this is actually one of the McKinsey article, which I quite like to read because they really give you something more about the real world situation. And essentially, this is really showing you the likelihood of some of this disease burden. And that is we're all living in an aging society, right? And this is really, with increasing aging, there's also a changing in disease burden, right? And what you can see is some of these are A, B, C, D, A, B, and this is C and D overlapping. These are really giving you a lot of cases. And these are cancers, cardiovascular disease, chronic respiratory disease, diabetes, and kidney disease. So really, these 4 groups of diseases, we as doctors are going to encounter them in primary care, in also secondary care, and we really need to know about these diseases very well and how to actually manage them and prevent them. So, as I said, statins is really a classical example of clinical observations leading to drug development and clinical trials. So many of you might not know, actually, there is this very famous Framingham, town, in the US, a very small town, but very, very detailed documentation of the risk profile and outcome in a very small cohort. And that is extremely informative. In fact, the documentation of risk factors, which are for example, glucose, lipids, and blood pressure really came from this cohort, very well followed up systematically and showing repeatedly the linear relationship between cholesterol and also cardiovascular disease. And this is subsequently followed by other sort of mechanical studies, trying to show in animals how actually lipid can cause atherosclerosis. And in actually 1987, that actually a Japanese scientist has discovered a statin, which is lovastatin, and this was really the first class of drug. And once you got a drug, then you can actually start intervening, and that's why drug development is very important. You can do so much with observations. You need to intervene, and subsequently there are different classes of drugs, but by and large, this is really showing you some of the key mechanisms. So here, this is the blood, this is the LDL cholesterol. This is really the waste product now. After all the fats and particles are broken down, this LDL actually bind with the ApoB in the circulation, and they are taken up by the LDL receptor, and then this will then be actually formed cholesterol, and then it will actually taken up into the liver cells, and then it will go into the bile acids and to be excreted. What happened is actually the HMG-CoA reductase inhibitors. It will actually inhibit the conversion of the acetyl-CoA to cholesterol. And so as a result, they will actually increase the uptake of this LDL cholesterol into the liver cells, so that you will be clearing the cholesterol from the bloodstream and then through excretion into the bile duct, and then you will be excreted into the intestine. So apart from this, there will be also another possibility, and that is, by blocking the synthesis of the bile acids, there will also by binding the bile acids in the gut, and then there will also be more synthesis of the bile acids, which will actually promote more cholesterol being taken up from the blood circulations, and thereby reducing the cholesterol level. And the other one is actually ezetimibe, which is actually reducing the recirculation of the cholesterol back into the liver cells. And so by blocking that one, we'll be able to reduce cholesterol level. So in other words, there are basically a couple of pathway. The statin is essentially decreased cholesterol synthesis in the hepatocytes. The ezetimibe is to decrease the intestinal cholesterol absorption, and then the bile acid sequestrants is to increase the bile acid synthesis. And as a result, we will actually lead to decrease in hepatic cholesterol and increase the hepatic LDL cholesterol receptors, and therefore, take up more LDL cholesterol from the plasma, and then reducing the circulating LDL cholesterol. So indeed, as I said, this is really, you can, for a lot of these drugs, there's some stories behind it. You can read about it. But basically, there are really a large number of clinical trials. You can see many of these trials are in the region of, 4,000 up to 10,000 people. And essentially, they have been done in patients who already got ischemic heart disease. So this is for secondary prevention, or in people who are high risk. In other words, they have not yet got cardiovascular disease, but they have multiple risk factors, in particular diabetes. And then primary prevention, and these are people who have actually got no cardiovascular disease in the background. And you could see that, of course, the event rate will be higher in those people with secondary prevention. The event rate will be lower in the primary prevention. But essentially, in all these trials, there is consistent evidence showing that whether these patients have diabetes or no diabetes, so this is actually the non-diabetic, and this is diabetic, there is actually about 20% risk reduction in terms of these cardiovascular diseases, extremely consistent in terms of these outcome trials. And in fact, there is also a linear relationship, and that is depending on how much cholesterol you reduce, the event rate is also reduced. So, for example, like PCSK9, we won't talk about it this time. The PCSK9 inhibitors can give you a very marked cholesterol reduction, like 50%. And then, here with the statins, and depending on the fibrates and ezetimibe. So statins have a potency which is between the PCSK9 and also the ezetimibe. And essentially, there is actually a dose relationship. But by and large, a 1 millimoles per per liter reduction in LDL cholesterol is associated with about 20% reduction in terms of cardiovascular diseases based on more than 50 trials and also 300,000 participants and 40,000 events. So on top of that, there are a lot of studies showing that, because statins actually have a very complex originated from plants, and some of these statins have been shown to actually have so-called pleiotropic effects. In other words, apart from reducing cholesterol, they can also, exhibit anti-inflammatory activities, antioxidant activities, and anti-thrombotic activities. So some of the trials, I won't name them, but some of the trials, people who came in with acute coronary syndrome, and even without reducing the cholesterol immediately, because it will take time for the cholesterol level to come down. People treated with statins and also versus placebo, even within 30 days, there is already a marked reduction in terms of cardiovascular events or sudden death, suggesting that administration of statins is associated with reduced inflammation. And of course, a lot of the inflammation of these plaques, is actually causing a lot of thrombosis. So some of these cholesterol plaque in the endothelium, they disrupt, and then it elicits a lot of inflammation, and that actually set up the whole cycle leading to thrombosis. So by actually giving these people statin, you can reduce that inflammation and actually make this plaque more stable, and then stop the thrombosis. So if there's anything, I hope by now you should really know about these three very important concepts, that is absolute risk reduction, relative risk reduction, and number needed to treat. So I hope we'll be giving you some of these questions in your exam, because this is really helping, because I think, we've done all these trials, the company always reported relative risk reduction, but in fact, what we're really interested, or rather people who pay for all these drugs, want to know the absolute risk reduction and number needed to treat. And this is really illustrating here. And of course, the FDA wants to, weigh the benefit versus the risk. And then really for the provider, they want to use the smallest number of amount of money to prevent the largest number of events, for cost effectiveness. And for the patients, they would want to actually get the best, therapy, and also with the least risk. So, how do you, and remember, these are chronic diseases. And that's the reason why when we talk about risk, we talk about lifetime risk. So although young people might actually have similarly low risk, but because they have the burden of disease for the next 30 or 40 years, actually the lifetime risk can be very high. So young onset people with young onset chronic diseases are very high risk individual in the long term. So this is really just giving us some example now. So I've already mentioned that, people treated with statins compared to those people who were treated with placebo, their risk of having CVD is 75% of that in the placebo group. That means the risk is actually reduced by 25%. So there's some difference when you talk about relative risk and relative risk reduction. So in other words, if somebody, they were not treated for, assuming that somebody's 10-year risk is actually 50%, in other words, 5% per year, then actually those who are treated, their risk will be 75% of the 50%, which become 37.5%. And of course, this is has to be, taken into consideration the background risk. So this is what we call absolute risk, 0.5 minus 0.375, which is 0.125. And the number needed to treat is 1 over ARR. So in this situation, you only need 8 to treat 8 people, in order to actually prevent one event, So when you think about it, sometimes you say, you actually have to treat 8 patients in order to get events. So it's not just a payment for one patient from a public perspective, from a public payer perspective. So you have to realize that, a lot of these, as I said, just now I show you the bars. They're all associated. Statin is associated with about 20 to 30% risk reduction. But depending on whether this is a primary prevention or a secondary prevention, then actually, the number needed to treat can be very different. So as a result, people have to actually assess the risk in order to make it more cost effective. So, for example, here you could see that actually the people who actually have high risk obviously don't have to treat a lot of people in order to get the benefit. And then when you actually come into people who've only got rather low risk, then actually, the number needed to treat is much higher. However, because the disease burden actually increased with time, so, the number needed to treat, sorry, this is a 5-year risk, 5-year number needed to treat, but you actually, for 10 years, the number needed to treat, it might actually comes down. So currently, we really talk about people, it's worth treating people if their 10-year risk is about 7% per year. So this is really the sort of cutoff that we are talking about. And so here, this is this is considered to be reasonable, cost-effective. So in other words, and about 30 people in order to prevent one event. And this become important when we talk about global risk assessment, because when you look at the lipid level, then how do you actually assess, whether this person is going to, whether we should be starting a statin. So, just a word about diabetes. For the same cholesterol level, you must actually interpret it within the context of that person. So, for example, for the same cholesterol level, or for that matter, for blood pressure level, or it will be, the risk is much higher in a person with diabetes, with pre-diabetes, or, for example, in a patient with obesity, because these lipid particles are actually altered in that environment. And so, that's why, for the same lipid level, people with diabetes always have 2 to 3 times higher risk for cardiovascular disease compared to somebody without diabetes. And this is really the UK PDS, which actually really demonstrating, the impact of reducing blood pressure and also reducing, blood pressure and also reducing glucose in terms of reducing cardiovascular events. But this is really just to show you that in terms of reduction of cardiovascular disease, the impact of actually reducing cholesterol and blood pressure is considerably greater in terms of A1C. So if we can reduce 1 millimoles per liter of LDL cholesterol or 4 millimeters mercury of blood pressure, we only need to treat, for example, 8 people in order to prevent, if you can treat 200 patients with diabetes for 5 years and reduce 1 millimoles LDL cholesterol, you will save 8 events. And if you actually similarly treat this number of patients for 5 years, you will save 12 events. Whereas for A1C, you probably only need to save 2 events. And this really highlights, how blood pressure control and lipid control are very important in preventing cardiovascular disease. Not to say that you're treating A1C is not important. This will have a long-term benefit, right? But the other thing is, of course, the microvascular complications are also very important. So that is really a little bit of background, right, regarding, the role of statin actually in reducing lipid and, their importance in terms of reducing cardiovascular diseases. So I'll pass this to Elaine, who will give you some idea, about assessment of risk. And while, these statins have a benefit, we'll illustrate 1 or 2 cases, where, some of the side effects you need to be cautious of. So, Elaine.
So Professor Chan has, outlined very nicely, a lot of the key, landmark studies. In the following slides, I would just like to, go through some of the maybe the guidelines and how we should, use statins in, for primary or secondary prevention in different populations. So I would refer you to this publication. So this is the 2018, AHA joint guideline on the management of cholesterol. The ACC and Joint AHA Task Force on the guidelines, so you could go and read that in detail. Essentially, there are some controversies between maybe some European versus American guidelines, but in general, I think there are some consensus agreements on general principles about how and when you should be using lipid-lowering drugs. So I mean, I think the premise is that, one is about, risk, about assessing cardiovascular risk. And, we should be considering lipid-lowering drugs based on, an overall assessment of their cardiovascular risk rather than just merely on the lipid level itself. And those particularly high-risk patients include those, with manifest, atherosclerotic CVD, and particularly also people with conditions such as familial hypercholesterolemia and also diabetes. So in people who haven't got these three conditions, then, how should we gauge, for example, these are patients with maybe just hypertension, obesity, or some risk factors, then what we should really use is to calculate global risk, based on these certain maybe established risk calculators, taking into account both, just lipid and also maybe non-lipid risk factors, which we'll go on to talk about that later. And I mean, I think one of the things that frequently people ask when you start starting a statin with certain patients and say, doctor, I mean, can't be a guy how, and so, I will, maybe, cut down my fatty foods, etc., or whatever. But I mean, I think this is also important, before, counseling people on starting on a lipid-lowering drug, you should also provide them suitable, lifestyle advice, regardless of whether drug therapy is used or not. And importantly, we should be using the LDL-C as the primary therapeutic target. Okay. So in general, I think unless there are absolute contraindications, statins should still be the first line lipid-lowering drug. And the intensity of statin treatment, should be gauged on the patient's, cardiovascular risk. So obviously, someone who's got, established ASCVD, you would consider much more potent, high intensity treatment. Okay. So who are the people who are very, very high risk of future ASCVD events? So basically, anyone who's had, a major ASCVD event, such as a recent acute coronary syndrome, history of myocardial infarction, history of ischemic stroke, and people with symptomatic peripheral artery disease, for example, those with claudication or previous revascularization or amputation. So these are very, very high risk group, which, really very high priority to start them on possibly high intensity statins were indicated. So other conditions where people may or may not have manifest ASCVD, for example, people who've got a history of heterozygous familial hypercholesterolemia, older adults, age 65, or people who've had a history of coronary artery bypass, diabetes. We'll talk about that later. Definitely, really sort of increases your risk for ASCVD by about threefold. Hypertension, CKD is also a very important predictor of cardiovascular risk, and we will talk about how we should use statins in this population. Smoking, okay. When people have got persistently elevated LDL cholesterol, that's above 2.6, despite maximal statin and ezetimibe therapy, those might be the populations we might have to think about, additional, may possibly newer agents. Okay, so I think these kind of the really high risk groups we should think about in terms of lipid lowering therapies. Okay, so we mentioned that diabetes really increases the risk of ASCVD. So what's specific relation to diabetes that would also increase that risk? So obviously, for people with very long disease duration, it may say over 10 years for type 2, or over 20 years with type 1 diabetes. So albuminuria is also a very important predictor. And also people with lower EGFRs, less than 60, people who've got also already got concomitant microvascular complications such as retinopathy, neuropathy, or who've got suggestions of the PVD. Again, these are diabetic patients who will be at higher risk of cardiovascular complications. Okay, so but I mean, I think again. we are covering a very wide population, and there are some specific considerations we might have to think about. So, for example, in the elderly, for example, those are over 75 years. I think because some of the patients might have high levels of comorbidities or might have limited life expectancy. Again, this should be an informed decision, where you weigh the pros and cons, and with an individual consultation. In theory, statins mostly have been demonstrated to be safe, although based on smaller amount of evidence in the older adults. But again, these can be prescribed with caution, taking into account of potential polypharmacy or potential drug-drug interactions, and you might not want to prescribe the very high intensity statin therapy in these individuals. Okay. So what about people with chronic kidney disease? So essentially, evidence says that the statin therapy is beneficial in pre-dialysis patients. So again, this because they are such much higher risk of future ASCVD events. So really, I know Professor Chan really make sure that all our CKD patients are put on statins, and sometimes this might be overlooked in some. Okay. Again, we absolutely type 2 diabetes. Patients should receive statin therapy. And we mentioned about those, with documented CVD and patients with ACS. So in terms of primary prevention, okay, so I think this is an area which is, possibly a little more grey but essentially, I think the evidence is, for adults, with a 10-year risk of ASCVD, greater or equal to 7.5%, or maybe depending on the risk score you use. Essentially, people of higher risk, 10-year risk, and who have got the cholesterol above that threshold might be candidates for primary prevention. But again, this kind of conversation might need to be individualized with the patient. Okay, so. In reality, how well are we managing patients with statins, and how many people at goal? So this is quite depressing statistics from the United States. And in that study, only 50 to 60% of patients with diabetes who did not have CVD were actually treated with statins and at LDL goal. Okay. The statin, prescribing rate, is actually very, very, maybe not as high as we'd like, and definitely not necessarily improving over time. I think we mentioned, in these people for primary prevention, we would maybe need to determine an estimation of the ASCVD risk. So this is one of these risk calculators. This is the pooled cohort risk calculator, which is available at this clinical website, and which you can apply. So I would encourage you, when you encounter such a patient in your medical clinic, for example, then just a few quick minutes to identify the key inputs, variables such as gender, age, the cholesterol, smoking status, and you can very quickly generate an ASCVD risk evaluation, which is informative for the patient and also as well as yourself. And I think these usually come as a very a graphic which illustrates very nicely. For example, in this person, if without treatment, the 10-year risk of ASCVD is 34%, but this risk can be reduced to 3.6% with optimal risk factors. Okay. So I think we mentioned just now, so again, this is a person, with no diabetes versus diabetes. So with the same level of, cholesterol and other risk factors, a person with diabetes will have a risk of 34% versus just 20% if someone without diabetes. Okay, so So, we talked about all the benefits of statins, but obviously, statins is not without side effects. And this is, apart from, therapeutic inertia, this is one of the reasons where those patients might be reluctant to take statins, or sometimes clinicians might be stopping these statins because of worries about certain side effects, and particularly the statin-associated muscle symptoms. So, this actually occurs in a whole range. This, ranges from just, myalgia, where people have a normal CK or creatine kinase. This is, actually very infrequently reported in RCTs, but in clinical settings, I think probably approximately 5 to 10% of patients would report some kind of muscle symptom, but don't necessarily have a raised CK. However, when we're talking about, more worrisome, with myopathies, such as people with rhabdomyolysis, actually this is relatively rare. So we're talking about people with a tenfold rise in CK above the upper limit of normal, and actually that's very, very rare. Okay. Again, other potential side effects such as the transaminase elevation, very high levels are actually relatively infrequent, and some of the other concerns such as hepatic failure is actually very, very rare. Okay. So this is concerning rhabdomyolysis. Actually, we at Prince of Wales Hospital did an 8-year review of all the causes and outcomes of patients with rhabdomyolysis, and we actually tried to look at all the ICD codes of rhabdomyolysis from the EPR data, and we only identified 95 patients actually diagnosed with proper rhabdomyolysis with a raised CK above tenfold above the upper limit of normal. So actually, amongst these cases, the average age was about 72 years, and the median max CK value was about 9,800. And out of these 95 patients, 8 cases were fatal. And we'll underline one of the potential very important factors is the deterioration of renal function. So at least 70% of patients had also concomitant acute kidney injury when they had this episode of rhabdomyolysis. So, what is the most, common etiological factor? Actually, the top one was trauma, followed by statin. Actually, out of these cases, only 9 cases were implicated with the lipid-lowering drugs. So simvastatin in 7 cases and fibrates in two cases. Other causes, for example, include things like seizure, heat stroke, exercise, and rarer muscle disorders. You could see that actually, a few of the cases were fatal, but also you could see that a lot of the cases had concomitant acute renal failure, and a lot of the cases also had multiple causes that are contributory to the rhabdomyolysis episode. Yeah. So, just for example, one of the cases was a 50-year-old lady who had diabetic nephropathy, hypertension, and obesity. And she was admitted with a urinary tract infection and acute renal failure. And her creatinine went from 327 to 651. So actually, after that, after she developed acute renal failure, then they noted her CK to increase with a peak up to 39,000, and she was in a very dangerous combination of drugs with benzofibrate and also ezetimibe, and the drugs were actually withdrawn, and then the patient eventually recovered. And this is just a graph to highlight that the relationship between the rise in the peak creatine kinase and also the serum creatinine. So just to underscore that, in these cases, obviously there's maybe a combination of drug, patient factors, and also maybe acute, other acute intercurrent illnesses which would lead to such an episode. Okay.
Okay.
So
thank you. So actually, on this particular case, actually, I remember I wasn't really quite sure whether this patient was actually treated with statin in the background.
I think probably it's a statin.
Yeah, he was actually. So this patient, so it's a classical scenario. So she had diabetic nephropathy, she had hypertension, and then over time, right, her creatinine has already gone slowly creeping up. So this patient's already got some renal impairment, but she has previously got some, muscle pain with one of the statin, and then she was changed over to another statin, and she was tolerating it. But because of probably poor glycemic control, whatever reason, her triglyceride was also very high, and so she was given bezafibrate, and then she developed urinary tract infection, and so the renal function get worse. And once the renal function get worse, then actually this will have the impact on the fibrate level, and also the statin level, and so the statin level, which was previously tolerated, that became toxic, and as a result, she actually developed rhabdomyolysis and kidney dysfunction, and the whole vicious cycle actually sets in. So I think this is not an uncommon scenario. And there was another patient that I saw, and still in the GOPC, right, in the general outpatient clinic, people have been given gemfibrozil, okay, which is an even older fibrate, because in the old days, people were just, they just treat the triglyceride, because people with diabetes tend to have high triglyceride because of poor glycemic control or insulin resistance. And so, this was like 20 or 30 years ago, and may not be put on statin, or subsequently put on statin, but it was kind of okay when the renal function was all right. But then after 10 or 20 or 30 years, then kidney function gradually, deteriorate. And this is really the time when periodically you will have to actually review the medication history, because this is really one of the problems with all these patients with chronic disease. Where kidney function is may actually go, may slightly deteriorate, or even with aging, kidney function might go down, and so drugs interactions might happen. So I think with that background, I just thought, we'll take the opportunity to talk a little bit about, the PK and also the PD of statins, because this is such a common drug, right? And because it is so effective, and so many people have cardiovascular, renal disease, or who are at high risk of cardiovascular disease, and that statin has a place. We need to understand a bit more, about the PK and PD, as well as the pharmacogenetics, because maybe one of the reasons why a lot of people are not quite willing to take statin is because that might indeed be a little bit of a side effects, and this might be related to some of the interethnic differences in terms of the pharmacogenetics, and that's actually statins. We might need to use a lower dose in the Asian population, and some of the work was actually firstly done in this hospital, and I thought you ought to know this. Now, there have been really multiple statins being developed. Initially the first ones were lovastatin, but later on it was the company did not further develop it, and then really the next one was simvastatin, okay, and then the atorvastatin also came on, and so one is by MSD, the other one is by Pfizer, and then they really did a lot of landmark studies. So these really two statins has actually set the benchmark for many other statins to follow, and so ultimately some of these statins came off the market, or were not marketed because they don't have the landmark studies to support them. But the third one in town is actually rosuvastatin, a very, very potent statin, and they were the one that had been, tested in primary prevention of cardiovascular diseases, and also, very popular. But this is also the one that we really need to be particularly concerned, because there is major interethnic differences in terms of the doses that should be used, okay, for this particular drug, rosuvastatin. Now, so really, these are some of the key PK parameters that I hope you're familiar with: the absorption, the distribution, the metabolism, and also the excretion. So most of these drugs, the bioavailabilities averages about 20% or so, and these are the standard half-life. And most of them are Most of these are, they keep in the circulation. These drugs are subjected to metabolism, by the P450 enzymes. This is of course a very important class of drug, where a lot of drugs and also endogenous substances are actually metabolized. And this is also where you can have a lot of genetic differences. And this accounts for a lot of the idiosyncratic reaction, and also, some of the differences in terms of the clinical responses, notably, for example, like warfarin is another one, statin is another one, for example, clopidogrel. And these are really why Asians, the reason why Asian actually require a lower dose is because some of the SNPs, which is associated with this cytochrome 450 system, which is associated with altered activity, would actually they have a greater representation actually in the Asian populations. And I think statin is a very good example to illustrate, these points. And also, remember that some of these hepatic enzymes, they actually may actually activate a prodrug, to an active drug. So if there is a reduced activity, then the drug will not be activated, and there will be reduced activity. So on the other hand, some of them they are obviously involved in deactivating the drug, and so if there is reduced activity, then the drug might actually accumulate. More importantly to note is because many of these patients might have coexistent disease, then we have to be aware, whether these drugs are primarily renally excreted. And among, the three most common statin, actually atorvastatin is predominantly metabolized by the liver, and only a very small fraction is excreted by the kidney, making it sometimes the preferred drug in patients with CKD, whereas, the other two drugs, they still have a significant renal route in terms of excretion. So, this is really, particular Japanese have done a lot of work in this area, right? I mean, the Japanese I think they are very sort of careful, right? They are very systematic, and in terms of drug evaluation. So they always demand that any drugs that go to the market, they need PK study to be done in that population. And sometimes some of these differences between ethnic groups are first reported by them. And statin is one of these drugs. So here you could see that actually they first reported that actually Asian people need a much lower dose of rosuvastatin, compared to the Westerners. So Crestor is the trade name, right? Atorvastatin, Lipitor is the trade name. So in this, they look at the studies, and here this is an Asian population, these are Westerners, and they have similar baseline the LDL cholesterol. But interestingly, here, this is only after 10 months, whereas the Western people is after 2 years. Actually, they reach similar LDL cholesterol, 44% reduction in LDL cholesterol, but actually in a considerably lower dose. So we can achieve this reduction using a mean dose of 15 milligram actually, as compared to 40 milligram in the Western population. It's highly significant. Whereas, for example, for even similarly for atorvastatin, we saw the same pattern. So for the Asian population, again, despite a shorter period of exposure, we have a greater similar reduction in terms of LDL cholesterol. And again, with a considerably mean dose of only 20 milligram as compared to 80 milligram, in the Western population. So at least, in the label, they recommend actually the maximum dose, for rosuvastatin is only 20 milligram in the Japanese population. And then, when the Western population is up to 40. And for atorvastatin, we only use it up to 40, whereas the US population is 80. And for simvastatin is 20 in Japan, and also in 80 for the US population. So you have to be aware that some of these some of these doses, when we prescribe, because sometimes you look at the landmark studies, a lot of these landmark studies, sometimes they use dosage, which is actually tailored for Caucasian population. And some of these you need to note. Now, why should these differences in terms of the drug level? So we have to think about that in terms of the pharmacogenetics, right? And so these are some of the key enzymes and transporters, okay, which are implicated in the sort of statin metabolism. And these are some of the, some of the candidate genes that are actually implicated. This is one is actually the ABCG2 and then also the SLCO1B1 gene. So these are the genes which are actually involved in transporting a lot of drugs and also endogenous substance. So particularly here, for example, these are the anthracytes. Okay, and basically, the cholesterol is actually or the drugs. Okay, so when the statin is absorbed, okay, so they are pumped into the circulation through the SLCO2 into the circulation. Now, then there are the other drugs, okay, which is actually the ABC. They have many subtypes, okay, which can be ABCC, ABC B or ABCD, so forth. But basically, this co-transporter is responsible for the efflux, okay, for getting rid of the cholesterol, okay, into the lumen. And also in the liver as well. So here you could see that actually the blood, as the statin is actually carried by the SLCO transporter, okay, into the bloodstream, and then they go into the liver to carry out its action by inhibiting the HMG CoA reductase, and therefore, inhibit the intrahepatic synthesis of cholesterol, and therefore reduce the cholesterol level. So, if there is any, altered activity, okay, of this SLCO1B1 gene, then there might be increased, okay, level in the blood, okay. At the same time, here, once they are in the hepatocytes, okay, they also later on has to be efflux into the bile. So if there is reduced activity of this ABCB gene, then again, there may be increased, okay, accumulation of the drug in the circulation. So these two are actually exhibit quite a lot of interactive differences, okay, in terms of the SNP distribution, and this have lead to differences in terms of the drug level and potential differences in terms of the lipid responses. The other ones are, the LDL receptors and then HMG CoA reductase, okay, as well as the CYP2D6. But in terms of statin is involved, I think we concentrate on these two. So this is really just showing you, okay, some of the genetic polymorphisms. Okay, so these are the ABCB1 gene. Okay, this there are these SNPs. Okay, I think by now you should be, because genomic medicine is going to come into practice. Okay, so I think you need to be familiar with the language. So some of these SNPs, okay, they are associated with amino acid change. Okay. So all these SNPs are given a certain number and depend on the code, okay, whether this is C or T, okay, these are where the polymorphism comes in, okay, one is minor allele, and then the other is the major allele, and then, some of them are changing the amino acids, some of them are silent, in other words, they don't change the amino acid, and so the protein is not particularly altered, but these can alter the function or the structure. These are actually associated with only minor effects, okay, in terms of the transporter activity for statins. Also, the other point to note is actually these are common polymorphisms, okay, and so there is this possibility of different combinations, okay. So this is what we call haplotype. So, for example, you have people who can have TTT, in other words, they carry the T for all these three SNPs, okay, or you have people who actually carry CGC, for example, and you get one from mom and you get from dad. So again, all these, okay, if you really get all the haplotype, risk haplotype, then maybe you can have increased systemic exposure to some of these statin and simvastatin, which are actually mediated. The transport of these drugs are mediated through this co-transporter. But going back to this ABCG2, these two are important, okay. This is the 421C to A, okay, and then the other one is the SLO1B1 gene, which is the 521 T to C gene. Now, these are again, first reported by our group, okay, Professor Brian Thomason. This is really showing, how the SNP actually altered the rosuvastatin level, and subsequently these findings were actually confirmed in other ethnic groups. So for the ABC gene, ABCG2 gene. For these SNPs, okay, here you could see that people who actually got the 421AA, you could see that the drug level, okay, of the rosuvastatin is nearly double of the other CC genotype. The other one, okay, which is the SLCO1B1 gene, it is associated also with increased level of the metabolites of rosuvastatin, okay, but not with the original drug. But the important point is when these people who have actually both SNPs, then you could see that the rosuvastatin level is actually markedly elevated 3 times or so. Okay, so you could see, so there is actually evidence suggesting that, these genotypes can alter the handling of rosuvastatin. Okay, these are all in Chinese people. And subsequently, people started looking at this, and essentially, what we found that actually in some of these cohorts, the discovery cohorts in the Asia, is a big analysis, and basically this is Asia and Hong Kong. You could see that the rosuvastatin 10 milligram, the reduction of cholesterol level is around 47%, as compared to which is about 10% greater compared to the other compared to the predominant Caucasian group. So and then, in this analysis, they also show, again, really looking that the combination of these two SNPs, okay, again, this is the SLCO1B1 and then the ABCB1, the haplotypes, okay, and for those people who carry these particular combinations, in fact, the rosuvastatin level is considerably higher than those who have actually do not carry these particular haplotypes. So, and the point to make is actually people there are these inter-ethnic differences, okay, in terms of this SNP frequency. For this particular one, okay, which is the ABCG2, which is responsible for the efflux of the drug, okay, in efflux of the drug out of the the circulation. Here you could see that actually the frequency is actually 3 times higher than the Caucasian, and that is the reason why. Whereas the SLCO1B1 SNP is actually similar, okay, but because of this higher frequency and of the ABCG2 gene, and together and because of the potential interactions, okay, between these two SNPs, that actually make the exposure of rosuvastatin, a lot higher, and so you could see that actually, for example, on the other hand, the Indian population, they actually have a lower frequency, okay, of these SNPs, and so for these people, they may need a higher dose of rosuvastatin. So I think these kind of interethnic differences is actually important, and I hope some of you would and we really need to understand this more, because some of these SNPs, they are also implicated in other drugs, okay, and also and also some of they are also sometimes handling some of endogenous material, for example, endogenous substance, for example, the lipid carriage, the iron carriage, and also cation, anion, and of course the cation and the anion, these are also can alter the transmembrane potential, because this is really a cell is not inert, okay? On a cell, there are expression of many of these co-transporters and channels. And in order to actually, this is what we call cell signaling, okay? So when something happens in the internal environment, there are changes in this ion. That's the reason why all this sodium, potassium, calcium, chloride are so important, and hydrogen ion, because once you change this ion, then this channel will be disrupted, and this is the way how the cells crosstalk, and in order to elicit responses in the cell, okay, whether this might be about function or function. And so, these SNPs can actually give us quite a lot of insight as to some of the disease predisposition, as well as sometimes the way of drug responses. Now, so that is a little bit of the interethnic differences, okay, explaining why rosuvastatin dosage should be reduced, okay, in Asian population, okay. So really, I think most of the people, we really should not be using like 20 or 40 milligram of rosuvastatin. In fact, it is actually in the label that in Asian population, the top dose is 20. And for me, I really rarely use, I only use 5 to 10 milligram because they are very potent anyway, and also because of their renal clearance, because they depend on the kidney to be excreted. So in patients who've got renal disease, you have to be also careful, have to adjust the dose. So I think here this is really showing you of all the drugs, okay, really atorvastatin is the one that is predominantly excreted by the liver, okay. So sometimes people will give a very high dose statin because this is also metabolized by the ABCG gene. And so sometimes we do find some people who got hepatic, dysfunction because of the accumulation. So sometimes we have to be a bit careful. But generally speaking, 10 to 20 milligram atorvastatin is pretty safe, even up to 40 milligram. And this also because they are not actually excreted by the kidney, so you don't need to adjust the dose, okay, during in people with the kidney dysfunction. But rosuvastatin, here even in Caucasian population, they are actually recommending a reduced dose, halving the dose, or even, halving the dose, okay, when people actually got significant renal impairment, 15 or less than 15. And for fibrates, okay, fibrates are predominantly excreted by the kidney, okay, and again, if there is accumulated level of fibrate, they can also cause the rhabdomyolysis and cause problem. And here, really, the old-fashioned gemfibrozil should not be given at all in patients who actually got CKD. So next time when you see people who are actually still on gemfibrozil, okay, who are referred from the GOPC, take the opportunity to change them over to fenofibrate. Even then, people who are actually have significant renal impairment, you still should actually reduce the dosage of fenofibrate. There are some situations we might have to give both drugs, okay, and this is really where the statins and fibrate PK interactions can occur. And so, the co-administration of statins and fibrate can actually increase the statin level by 1.58 to actually twofold. So next time when you actually give statin, people about statin, and then, if these people have very high triglyceride and you really do need to give these people fibrate, you have to watch the kidney function and then also, have to cut the dose accordingly. So, these are really important because of the potential adverse effects of rhabdomyolysis. Okay, I really just want to finish off with giving you a very interesting example, right? And because of this inappropriate use of this dosage of rosuvastatin, it has led to the failure of a drug, okay? And this is really one of those blunder, and that actually is has been sort of it's very well known among academics, and really telling us that you have to be careful when you use dosage. So this is really just to remind you that, there is very close relationship between renal dysfunction and also albuminuria with cardiovascular disease and all-cause death. So, with the albuminuria, there's essentially no threshold. So with increased albuminuria, there is increased cardiovascular disease. So just to remind you, the kidney is really just a bag of glomeruli. These are all small vessels, okay? So, millions and billions of capillaries. And so really they are a very good organ demonstrating them very sensitive to vascular health. So if they are exposed to 20% of blood flow, and so, with the hyperglycemia, hyperlipidemia, and high blood pressure, the damage of this glomeruli, okay, would be reflected, okay, in the form of albuminuria. Okay, so important to remember that actually sometimes, as these glomeruli lose function, the other glomeruli will pick up. Okay, so the eGFR doesn't fall that much, right? Because you start with 100, and then you kill 10, and then the other will work harder, and then so forth, and then suddenly, and this is the reason why kidney function suddenly deteriorates rapidly, because once you reach a tipping point, right? Because we now lose so much kidney function, and then the others have been overworking. And so, when you now actually lose a significant amount of kidney function, then actually the other one cannot actually cope anymore. And so this is the reason why we have this, exponential increase in serum creatinine, and so something to think of. So even if you see somebody, having a serum creatinine of 200, which might be a eGFR of, for example, 40, don't think that it will take another 2 years for it to go from 200 to 400, because, it will take very short period of time, and then it can shot up to 400. And this is what I call the single nephron theory. Anyway, when it comes to the eGFR, once these people lose eGFR, then internal milieu will be, worsened again. There will be more inflammation. There may be anemia, abnormal calcium metabolism, and so these people, the vascular risk actually markedly increase, and really starting around about 75 eGFR, there is this progressive increase in terms of eGFR. So because patients with diabetes and chronic kidney disease, okay, they have so many abnormalities, okay, in terms of high glucose, lipid, blood pressure. So people would, once they get CKD, the risk of cardiovascular disease is markedly increase. So now the latest guidelines say, that's actually, really should be optimized all the risk factors, okay, including lipid management. And then, of course, now we have all these new drugs, apart from RAS inhibitors, the SGLT2 inhibitors, in order to slow down the decline in kidney function. And indeed, our own experience is if you can actually manage these patients, with all these risk factors, reduce all these risk factors, and not to forget about, the lifestyle modification, you can really slow down the rate of decline of eGFR quite dramatically from 4 ml per minute per year to, for example, 1 ml per minute per year. And thereby you can really delay, the requirement of dialysis. But of course, that requires a lot of careful drug manipulation, drug management, and also lifestyle advice and frequent monitoring. So this is really just to remind you, and I think really you really should know this. And these are questions that we'll be asking in the final examination. How do you grade the CKD, right? The grade 1, 2, 3, 4, 5, all the way from 90 to 15, that is when you need dialysis, and also the macroalbuminuria. And these different colors really represent the risk for CVD. So this is the study that I want to tell you. This is called the Planet 1 study, okay? There was actually 2 studies, Planet 1 and Planet 2. Okay, one is in people with diabetes, the other one is without diabetes, okay? And this study was performed, and it took a long time for it to be published because the results was very disastrous, okay, for the sponsor. And so, not very nice for the PI as well. But essentially, they want to ask the question whether rosuvastatin can actually protect the kidney. The background being actually there is a very famous study called Treat to New Target, where actually atorvastatin, okay, which is 10 milligram, 80 milligram, okay, so these are really no placebo group. Well, it's just 10 milligram and 80 milligram, and then to treat so that the high dose to treat to new low target, which is to LDL 1.8. And then they found that obviously people treated with high dose atorvastatin, this is again not the dosage to be used in our population, maybe 40. There was actually a greater reduction in cardiovascular diseases. But in a post hoc analysis, they also found that there was a much slower rate of decline in terms of eGFR. So in that study, it was suggested that actually, lipid lowering agent can also protect the kidney. And so in this study, because the rosuvastatin was the third drug, okay, that comes in, and they need to find new indications. So they actually wants to ask the question whether rosuvastatin would protect the kidney function. And so they have to test it against atorvastatin, right, because that has been reported. And so what happened is they actually used a low dose and a high dose. Now, remember, they were actually using these patients who actually got renal dysfunction. These patients have severe albuminuria, okay, and they have high lipid, okay, and they were already treated with ACE inhibitors or ARB, and so they just want to do 6-month studies, okay. So that this was really, this was actually about only about 39 weeks, okay. So what happened is they were randomized to 3 groups. So, to their surprise, they found that actually, they were out there, and they end up, randomized studies, they actually now proven that actually atorvastatin was actually really did reduce the proteinuria. And this is also the albuminuria. Okay, this is the microalbuminuria. This is actually the macroproteinuria. Whereas actually, the rosuvastatin did not do very much. Okay, so when it comes to albuminuria, it did something. But by and large, actually, they were not very effective in reducing albuminuria. But what's even worsening is actually, what was even worrying is actually they actually reduce the rate of decline of EGF was actually greater in people actually treated with rosuvastatin, and then which is actually stabilized, okay, in the case of atorvastatin. And if they use retinol binding protein as a marker of renal damage, they actually show that there was actually some degree of renal damage, and then there was also some adverse events, okay, that people were treated on very high dose of rosuvastatin. There was actually, some doubling of serum creatinine. There was acute renal failure. So it wasn't really very good, okay. So it took a long time for them to actually reveal all the results. So finally, they had to publish it, right? They cannot actually not publish this result. And subsequently, I think it was transcends that actually probably they were using too high a dose, okay, 40 milligram. And these people were already got renal dysfunction. And knowing that actually, and probably knowing this, that's actually, and we don't know whether some of these patients might also be treated with fibrates, etc. And so it really highlights the importance of understanding the pharmacokinetics of a drug, particularly in the context of renal dysfunction, in order really, in order to avoid some of this harm. Okay, so I want to finish up by really, telling you how beneficial, the sort of, the impact that we can make by really making sure people, really by reducing blood pressure, LDL cholesterol, and A1C. This sounds all very mundane, right? But not very exciting. But the point is, after all, we are here to save life, okay, to prevent, unnecessary hospitalization. And these drugs have been around for 30 years. The evidence is very powerful. And only we can actually evaluate these individuals, give them the right drug at the right time, we can do a lot of benefits, okay. So this is really just to show you of the 3 risk factors, okay. I don't have time to talk about the other sorts of meta-analysis, but essentially, if you can, there is good evidence showing that if you just reduce 1% of A1C, you can reduce, for example, 9% of cardiovascular disease, okay, 50% of ischemic heart disease, if you reduce 10 millimeters mercury of blood pressure, particularly, you can again reduce about 10 to 15%, okay, in terms of stroke and also cardiovascular death or ischemic heart disease. And when it comes to lipid, okay, you can actually reduce again about 20% of cardiovascular disease, ischemic heart disease, or stroke, if you treat these people adequately for 3 or 4 years. These are based on large randomized clinical trials. And so in this particular reports that we compiled together for Lancet, so we, there's now a global epidemic of diabetes, right? And 450 million people have diabetes. And the thing is actually 50% of these people are living in low middle income countries, okay? So, so these are, and we estimated in these 10 low middle income countries that include places like China, India, Brazil, and so forth, right? You can actually expect every year about 3 million people dying because of cardiovascular disease, died. And of these, okay, 50% of that is actually due to cardiovascular diseases, all right? Now, only if among these people, okay, if we can actually make sure that they are actually treated by lowering the blood pressure, okay, and of course the impact is greater in people who got higher blood pressure, and then reducing the cholesterol, you can actually reduce nearly 800,000. This is really adding together. This is nearly 1 million deaths. Okay, so. among these people. So, the point I want to ask is, of course, Hong Kong is a high-income country, okay, but remember, I think treating these basic risk factors are very important. Recognizing these risk factors are very important because cardiovascular disease is still the leading causes of death, okay, in Hong Kong and also, in China and beyond, and that these risk factors, can be effectively managed by using these drugs. But of course, carefully, and in certain situations, you have to review the medication dosage, particularly in the context of aging and also development of chronic kidney disease. So I think in summary, so I hope in this ground round, we have given you a little bit of insight, how drugs are being developed, a 30-year history of statin, okay? So take a lot of people's effort and career to develop these drugs, okay, to demonstrate, accumulate that evidence. And starting from the epidemiology, okay, the relationship between cholesterol and cardiovascular disease, and then the drug development and the clinical trials, really conclusively showing, how reducing lipid, LDL cholesterol, we can change the trajectory of CVD. And indeed, statin is really one of the most cost-effective drugs that can save life. Although there are still a lot of treatment gaps already highlighted. There are a lot of people who already have coronary interventions, but then they actually will not actually put on statin, okay, or, people are very high risk for cardiovascular disease, they're not put on statins. And so this is really, considering, how cheap statins now, right, and how expensive some of these procedures are. The differences in PK and PD as well as pharmacogenetics may explain some of the interactive differences in drug responses, drug-drug interaction, drug-host interactions. And I've illustrated some of these, particularly the ABCD gene as well as the SCLO genes. Okay, so these two are very common, and some of these SNP variants are not uncommon in population. So for some of these for some of these statin dosage, we really should be using a lower dose. And then we need to assess the global risk to identify high-risk individuals, okay, for both primary and secondary prevention of CVD. And there are calculators that you can easily Google. And then, so when you're facing a patient, you can look at the lipid, look at the other risk factors, the glucose, the blood pressure, the age and sex, and give you some idea what is their 10-year risk, okay, and if it is more than 7.5, then really the statins might be an important tool for you to reduce that risk. Important message, if for this ground round is, avoid the combined use of fibrate and statin, especially in the presence of CKD. Do not use gemfibrozil, okay? And if you use fenofibrate and statin, then avoid using rosuvastatin. I think really should be using atorvastatin, okay, because they are less renally excreted, because the combination of both will increase the level of statin, and what is previously a safe dose would then become a very unsafe dose. And I think the lessons for statin highlight the importance for physicians, okay, to understand drug mechanisms, okay, PK/PD and evolutionary evidence in order to maximize benefit and minimize harm during prescribing. So when we prescribe, you are actually it's a very powerful way of changing people's outcome, and so use it appropriately. So with that, let me know if you have any questions. So I don't know whether, Jones have any, I realized that there was, just going through the literature, you guys have actually reported a case, right? Where it's actually rosuvastatin together with Synva and also with linagliptin. Oh, no, with linagliptin and also one of the TCM.
Well, the herbal supplement, sweetener, artificial sweetener. Yeah.
And because both of them are actually, and this person have a SNP, right?
With the enzymes or the P450 enzymes.
Yeah, that's right, you see. So sometimes again, watch out, I think some of these clinical observations, I still find general medicine very interesting, right? Because sometimes it's, it's holistically, looking at the person, right? As a person, the multi-system, and, the disease process, the host, the drug interaction and drug-host interactions. So, what do we have? Any? May I know when will fibrate be used in the treatment of dyslipidemia? Is statin alone enough to? Yeah, interestingly, yes. Very good questions. Okay, so triglyceride is elevated. Okay, there are many reasons. Okay, very often it's due to diet. This is the one actually due to diet, particularly high-fat diet, but also high glucose diet. Okay, sometimes we talk about fatty liver. In fact, actually, fatty liver is due to drinking too much sweetened drinks. Okay, so I won't go into detail, but actually there's crosstalk between glucose. In fact, the glucose is both glucose and triglyceride are fused. Okay, and you should still remember the random cycle where actually the glycerol, okay, from the free fatty acid can be turned into glucose and vice versa. So in fact, if you drink a lot of sugar sweetened drinks, okay, then actually you got a lot of fatty liver. Of course, if you're a lot of fat as well, right? So, so that is of course important through dietary manipulation, and also the other one is exercise, right? Because your triglyceride has to be catabolized. There's some of these enzymes, okay. So here you have chylomicron, then you to VLDL, LDL to IDL, then and then LDL and HDL. So at each site there are these enzymes, and these enzymes are very responsive to insulin. So if you have insulin resistant obesity, then some of these enzyme activities are altered, and so you have this high triglyceride. So reducing weight, okay, and also changing lifestyle. And the other one is of course the people who are very short of insulin. So people who have very poor glycemic control, if they really need insulin, they need insulin. They can have very high triglyceride, and so these people they need to have insulin in order to correct the hypertriglyceridemia. So. And that also is shown that, and then there are several of the statin, particular atorvastatin, they can actually reduce the triglyceride as well. So the only situation, so even people who've got slightly higher triglyceride, you still would actually treat them with statin first. Because if you've got a lot of high triglyceride, then actually the cholesterol level is actually, the LDL cholesterol is actually very toxic as well. So you even though the LDL cholesterol looks normal, they are actually not normal. They actually are very triglyceride rich. They have a lot of LDL, ApoB, etc. So they are very atherogenic. So so these people should be protected with statin because that is where all the sort of evidence comes in. There are situations when people got very high triglyceride, like over 8 or 10, then sometimes these people might actually have genetic abnormality, okay, which give rise to hypertriglyceridemia, and these people are at risk of pancreatitis. Okay, and so these people, you do need to give them fibrate. Okay, and so those are the situation when you need fibrate. There are some evidence showing that in people with diabetes, for example, if they are treated with statins, okay, but after they have been treated with statins, and then if they have retinopathy or nephropathy, sometimes the use of fibrates, particularly if they also have high triglyceride or metabolic syndrome, that also seems to confer some benefit for microvascular complications. So there is some evidence for that. But by and large, I think, putting these people on an adequate dose of statin is good enough. Okay.
I think it is relatively risky to put the patients on combination treatment with fibrate and also statin.
Yeah.
So provided that if you provide regular monitoring of the patient's renal function and also the maybe the CPK, it is justified. Otherwise, if you work as a general practitioner, you do not have a regular monitoring of the patient's blood profile, it is rather risky.
Yes, that's right. I personally came across 2 cases like that. Yeah, and sometimes, these people really, they just silently deteriorate, right? Yeah. So I think we have 1 or 2 occasions like that, which is not so nice. But I think now with the complication screening, right, that really helps a lot. So, okay. So is it right to say that the other lipid-lowering drug, fibrate and bile acid, are only used during specific situations? Yeah, I would think so. Yeah, fibrate is used. I think we usually use fibrates in people who really very, very high hypertriglyceridemia and who are at danger actually having pancreatitis. Okay. Yeah, so I don't use a lot of fibrates really, but I think if they have, well, as I said, if the triglycerides is still very high, and then these people are already on statin, and if you really feel that you have to use it, like what Dr. Chen said, use the fenofibrates, okay, and use the atorvastatin. Both of these are less dependent on kidney function. Certainly, atorvastatin is less dependent on kidney function, but you have to monitor the kidney function. And if the eGFR is less than 50, then really you should take them off the fenofibrates. Okay. And bile acids questions, right? This is really not so much used now, because I think the familial hypercholesterolemia, I think that might be another occasion that we can talk about it, but you probably should know about this, but that will take another lecture, because there is the genetic test coming in now, and there is this PCSK9 inhibitors, which are particularly useful in people who have actually got familial hypercholesterolemia, who are not responding to statin and ezetimibe. Ezetimibe is good, actually. The combination of statin and ezetimibe, I think, can actually reduce cholesterol quite adequately in maybe 60 or 70% of people with FH. But there are some people who really got very bad FH, okay? And importantly, people who got familial hypercholesterolemia, if they are confirmed on genetic tests, that means these people are exposed to a high cholesterol level, actually, from birth. Right? So you have to think about burden, disease burden, right? So these people can then have premature heart disease at the age of 30 or 40. And by the way, I can send around tomorrow there's a webinar by Professor Brian Tomlinson talking about familial hypercholesterolemia. So if you're interested in this, I think you can register. You can ask Maureen to send around the link. And then you can join this. However, it is like 9 o'clock in the evening. No, 8 o'clock in the evening. So 1 hour. But you need to update this, right? Because the PCSK9 is a useful drug as well. Okay. Any more questions? Sorry, I've taken up quite a bit of time. Okay, so I hope this ground round give you some some important principles, and I hope we will continue to use these ground rounds and lectures and e-modules and also our clinical attachment to inspire you about the importance of clinical pharmacology and toxicology, because we as physicians, this is one of our most important armamentaria. How do you use your drug effectively, and then really to prevent hospitalization, morbidities, and premature mortality, which I hope is all our common goals. And with all this genomic medicine, drug discovery, biomarkers, I think there's a lot of opportunity for people to go into this area, and get some new medicine, right, to help the patients. All right. Okay. Thank you very much indeed. Take care.
Thank you.
Thank you. Thank you, James. Okay. Thank you. Okay. Okay. 好啊。OK 啦，咁樣算啦，唔該晒啦。OK，好啊。